Good afternoon. Today we will be having an exercise on confidence interval. I'll be explaining more on the confidence interval and the clinical significance by a real-life example. So, what about antifibrinnolytics? Antifibrinnolytics are drugs that suppress the fibrinolytic system and thus reduce bleeding. So, will they be beneficial in patients with trauma? You know, patients like road traffic accidents or polytrauma, they come with bleeding. So, can I give them antifibrinolytic to reduce bleeding and reduce their mortality? Those drugs may reduce bleeding and thus reduce mortality. However, they have another downside. They may have another downside, which is creating a hypercoagulable state. And those patients are bedridden for long periods of time. So it might increase arterial and venous thrombosis. Arterial like myocardial infarction and cerebrovascular stroke, and venous like DVT. So would I give the drug or not? It depends on the experiment. I get the patients with trauma and divide them to receive either the new treatment, which is the tranexamic acid or the aprocitenine with whatever antifibrinolytic, or receiving the standard of care, which is no fibrinolytic. I may give them an empty ampoule as placebo, and measuring those outcomes of benefits and the risks, including the mortality and the thrombosis. So this is a forest plot from a meta-analysis available on the Cochrane Library about the subject. As you can see here, the neutral line here of this curve is 1, or this forest plot is 1, because we are using the risk ratio. Whenever you are using the risk or the odds ratio, the neutral line of the forest plot is 1, because it is the neutral point of the ratio. Okay? As you can see here, first, there are two drugs, the aprocitenine and the tranexamic acid. And regarding the aprocitenine, you can appreciate the width of the confidence interval. The width of the confidence interval of the aprocitenine is very wide. However, regarding the tranexamic acid, it is very narrow, which can be attributed to the very low number of patients in the aprocitenine experiment. The more patients you have in the experiment, the more your experiment becomes representative of the population, the more your estimate becomes very close to the real estimate in the population, and the more precise your results are. And this precision manifests in the width of the confidence interval. Check the width of the diamond here and there, and also the width here and there. This is first. As regards the aprocitenine, as regarding the mortality, you can see here, as you can appreciate, the two ends of the confidence interval are on the two sides of the neutral line. So the confidence interval has cut the neutral line. It's 0.01 and the other end is 2.67. And this can be explained as either evidence of absence or absence of evidence. However, here it is absence of evidence, because I'm not sure whether this aprocitenine, the antifibrinolytic, reduces mortality or not, because of the low number of patients in this group. So I may need more studies on this antifibrinolytic. Let's check on the tranexamic acid. Okay, this is the upper part of the curve. I just zoomed in a little. As you can appreciate here, the two sides of the confidence interval are less than 1, which means that the risk of the mortality is less than 1, which favors the use of tranexamic acid or the fibrinolytic. As you can see here, the ratio, if it is less than 1, so the fibrinolytics show less mortality or less of the adverse outcome, so they are favored to be used. And the other side, if they are more than 1, it means that they may increase the mortality and may not be used. So the two ends here of the confidence interval are less than 1. So the tranexamic acid significantly reduces mortality in the patients with trauma. But I need to translate this to more easy numbers. How can I do this? By calculating the absolute risk reduction and subsequently the number needed to treat. And how to calculate them? As you can check here, I have the total number of events in the antifibrinolytic group, the total number of events in the control group. Okay, and this is the total number of subjects here and there. What will I do? It's too simple. I will divide the number of events by the total in each group to calculate the risk of mortality, and then subtract them from each other. And this is what I have. The number that I have is called the absolute risk reduction. And by inverting this number, putting the numerator instead of the denominator, I get the number needed to treat. It will be 62.5, approximately 63. So you need to give the tranexamic injection to 63 bleeding trauma patients to reduce one mortality. You may argue that this number 63 is high, but we are speaking of mortality. And there is still things that we haven't discussed. What about the risks of this drug? As I told you before, this drug may increase, or the antifibrinloytics may increase the stroke or the myocardial infarction. Let's check here on this forest plot. It's also using the risk ratio. Check here the confidence interval. It's between 0.61 and 1.23. So this diamond or this confidence interval has crossed the line of neutrality regarding the stroke, the outcome of the stroke. What about the deep venous thrombosis or the venous thrombosis? It's almost the same. There is one end 0.62 less than 1, and the other end is more than 1, 1.47. So does the tranexamic acid increase stroke and DVT or not? Do I have evidence of absence that the tranexamic acid does not increase those, or it's absence of evidence and I can't be sure? We can check for two things. First, the event rate in the control group. Here the event rate in the control group is 42. The other example here, the event rate is 66, it's low. However, the number of subjects is very big. It's 20,500 patients in the total of the experiment. It's around 20,000 patients. So the difference that's not evident by 20,000 patients has two possibilities. Either there is no difference in the real life population and tranexamic acid is equal in risk to placebo or control in the risk of stroke or DVT, or the other possibility that there is a difference, but the difference is too small, because a difference that you cannot measure by using a 20,000 subjects, which is enough power, is small and clinically irrelevant difference. You know, just like telling you that I have a drug that reduces the blood pressure of the patient by 1 millimeter mercury. That's not a clinically relevant difference. So it's either there is a very little difference or there is no difference at all. So in summary, we have a number needed to treat of 63, which is a little bit high, but we are speaking about mortality. There is no risks of the drug. There is no increased risk of either deep venous thrombosis and thromboembolism or cerebrovascular stroke, arterial thrombosis, and this drug is available and is cheap. So how am I going to translate this into my practice? In each patient that's presented with trauma and bleeding, during taking the vital data, you might consider giving him the tranexamic acid injection to reduce mortality. That was all. In the next time, we'll be explaining about correlation and regression. Thank you.